Well, death is quite common in the hospital setting, right? If I take it as a very scientific point of view, death is an outcome. In the ICU, the outcome is often mortality versus survival. But whereas for a person, death is a real thing, right? Being able to know that every single death occurring is a loss to someone, and this person that has passed is very dear to them. My opinion about death has definitely changed over the years. In the beginning of my profession, I'm trained as a pediatrician, then an intensivist. It's always about saving lives. Fresh out of the medical profession, I think we deal with a lot about, the science. We talk a lot about science and evidence of diagnosis, of treatment, but we seldom talk about or learn about how to deal with difficult conversations and coming to terms with end of life. So I think unconsciously we are not prepared for that, and we are not prepared for that difficult conversations. And when faced with that, sometimes we still try to rationalize with science and evidence. When we talk about end of life, it's a whole new conversation. Being able to deal with the emotions, which can sometimes be very challenging for a person who has not been exposed or has not been trained. If we don't see death as a failure, we see that giving comfort is a success, then that changes the whole mindset. We always want to do more and more and more. And with medical technologies, there's so much more that we can do to keep the child alive, even at home. But being able to know that that may not be in the best interest of the child, not in the best interest of the family, I think that is important. And being able to come to terms with that is also important. A case that I seen when I was training overseas, a newborn that was diagnosed with a very complex heart disease, antenatally delivered via cesarean section to receive a heart transplant. The surgery went beautifully. It was a very successful surgery. However, I think the donor heart was a little bit big for this young baby, and they had difficulty closing the chest. So the child came back to the ICU with the chest open, with the hope that the chest cavity can be closed. Unfortunately, this was not to be so, and this child stayed for months in the ICU in open chest. Of course, was very traumatic for everybody because this child went through them bouts and bouts of repeated infections. We could see the mother, the parents going through the whole turmoil of this journey and multiple conversations. I think from the ICU team, the parents, I think it came to a point when the parents accepted that they saw the child, and to them, they felt that the child was suffering and they wanted to just give comfort care. However, the surgeon was not agreeable. In a way, I think it was a perfect surgery that the surgeon has performed. That this child was delivered to receive this heart transplant with the hope that this child would have a new lease of life. He couldn't accept that, and I think the conversations then went on between the parents and the surgeons and ICU team. So in a way, there's also a divisive kind of views among the medical team ourselves on what is the best for the child. So I think eventually this child did not survive another bout of infection and then passed on naturally. So I think even when dealing with death of a child, we must understand that we are not only dealing with family, we are also dealing with the expectations of the medical profession. And people can have very different views on what is in the best interest of the child. So oftentimes, for end-of-life conversations, for medical professions, we do have to come together, talk about it, and have a unified stance on how to approach this problem with the parents. Definitely my past experience with end-of-life conversations have shaped how I teach my younger generations. I think importantly is to teach them the need to listen and not to judge. Okay, we have our views about things, but it's important to listen and understand other people's views as well. So that has very much shaped also my leadership style, is to be able to listen to the difficulties of and the challenges what my staff face. So sometimes they may not be so open about sharing their difficulties when, let's say, for example, a job is not done, or they fail to deliver the indicators that they are supposed to deliver. So it's not to just judge them by the outcome, understanding their challenges, and be able to troubleshoot that, and maybe work with them on the challenges will be a big facilitator for them to move forward. And in fact, I think in healthcare, most people try to do their best. They really try to do their best. And then particularly for young doctors, they are very smart people. They really want to succeed in everything and deliver the best. So when they do not, there is often challenges that we must try to understand and be able to help them and along with it. So that's how I think all these experiences have shaped my leadership style, is to really listen to my staff and understand what they need. Well, there's definitely differences from being a leader. So when we are in the doctor's role, is a direct relationship with a patient. Of course, we work within the medical team as well, and we see immediate results. Let's say that child gets better, walk out. It's almost immediate gratification. That kind of endorphin rush is real. Whereas coming to leadership position, we have to take a more systems view of things. So the connection then may not be directly with the patients, but really at the systems level, how then through the systems impact more patients indirectly. And the leader must be able to accept that, and also be able to have the courage to know that for whole systems to work, sometimes little microsystems have to compromise to make the whole system work as a whole for the common good of the larger population. Definitely, time is a huge factor. Taking up the leadership role means that we have to give up on some of the clinical practice that I hold dear, which is ICU care, ICU work. But I try to keep in touch and still do clinical work because that's what I'm trained to do. But the leadership role also gives me a lot of satisfaction. On a larger scale, I can see a bigger picture. I can impact a bigger population. So having a balance of that, yes, some things have to give because we only have 24 hours a day, but being able to accept that we're human again, that we can't do everything, I think that's it. Yeah. Well, I've experienced a lot of deaths. I think it's due to my profession, but I will just give an instance of a most recent death that I experienced. It's a very acute death of a very young child to a mother, and I visited the mother after the child has passed. It was a very unexpected, unanticipated death. When I was there talking to the mother, I could feel her pain. I think it was unimaginable, and it was very tangible. It's almost I could feel her pain when she would talk to me. She was all curled up and she was just rubbing her chest. even in the conversation that I have with her, I could feel her going through the waves of the different emotions, trying to rationalize the guilt, the pain, and sometimes talking about acceptance, how she's going to accept that. And then she'll swing back to the guilt again. So the waves of emotion. And I think what I have experienced at that time with her was just tip of the iceberg. I think the journey is going to be very long. I really wish her the best. Really feel strongly with her, even after so many years of dealing with this kind of situations. It's never easy, and every case is very different. And as a mother who has a child of about the same age, I think that also affects me and makes me reflect on how I should also spend time with family and spend time with my children. Yeah. The way I deal with death in the early years is really about what I've learned in medical school is I must put evidence to everything I do. There's a science to it. There must be a way to cure this child. And if the child does not make it, well, maybe, the medications didn't work or the treatment that we've given didn't work, and that's it. Okay, maybe I've done my best. I didn't engage so much about having deep conversations with a family about either before or after the death in a depth that I would do now. I would just tell you the feedback that I had, which I think must be 20 years ago, that is still deeply etched in my memory and really shape how I then deal with parents. My experience overseas when I was working again in the ICU unit, when I was looking after a child after a major cardiac surgery. The child had a life-threatening event and we had to resuscitate and had to talk to the parents in a very matter-of-fact manner, your child has this condition and it became unstable, collapsed, and then we have resuscitated. There's a return of the circulation, but child remains critically ill. The mom came to me and said, Dr. Chan, thank you for saving my child. You're very calm. I saw your resuscitation. And then the next sentence struck me. You're so calm that you feel cold to me. And that really struck me that, I have perhaps relayed everything I needed to relay to the parent about the whole resuscitation process. But what I've not given them is the warmth that they need after such a bad news have been broken to them, that we are there to support them and we are also there to comfort them. So that comment really woke me up in a big way, and that sort of changed and see that, what can I do better? And sometimes the extra action of just holding the parents' hands and giving that reassurance and sometimes spending that moment of silence with them, I think that's enough. Death of a child is the most stressful event for a parent. And we have to understand that. We know that our duty is not always to cure. We can cure sometimes, but to comfort is a must. I think that's a very important part of medicine, and that's the soft side of medicine. And to equip young doctors with that skills. For example, if it is chronic patients and I've established a relationship with parents or the families, it is really just being there with them, especially if the death is expected. And so just being there with them, I think that's very important. Holding their hands, listening to them, and just the presence, I think that helps a lot. For children who suddenly pass, and particularly previously healthy children, what we need to do is also just to listen to them. They will be going through a lot of waves of emotion. Some may be very quiet, some may be very angry, but just being there and listening to them and empathizing with them, I think that's the most important thing. Also, the other part is yourself. How do you then relate to those emotions? How do you not judge based on what kind of emotions they've expressed. Sometimes it can be a lot of blame on the medical professions, not to be defensive, but understand the pain they're going through and the grief they're going through. And that is something that we ourselves have not experienced or may not have experienced, and to be able to empathize with that. I think that's the most important thing. And that's not easy to do, particularly for young doctors who have not had that experience before. If I'm talking to a parent or a caregiver when the patient is still around, then it's quite different from a conversation when the event of death has already happened. So it is actually broaching the topic of death, which in the context of let's say a chronic patient and a very acutely ill patient, again, is quite different. For chronic patients, we need to understand what the family wants. When death is not immediately or near imminent, we have a bit more time to spend with the parents to talk about that topic. And then is to walk the journey with the parents, understand their views about quality of life for their child, their own values, their own beliefs, and also the family support that they have. Those are very important. I think for those patients, the important thing is to come to a shared goal together with them, and then to be able to implement according to their wishes. And also, of course, for us, it's all acting in the best interest of the child. And the best interest may not always to cure, but to provide comfort for the child. For a child that, for example, have come in very, very seriously ill, the conversations that we have is usually more emotionally charged, particularly with the parents, because they have to accept a lot of information very suddenly. We often have to have multiple close conversations just to touch base with them to see whether they have understood what is spoken to them about. So a lot of times they are not able to absorb a lot of things, and we have to give it to the information, sometimes repeatedly in small sizes, and be able to judge how much they can accept and be able to pace that conversation well with the parents. Exploring the understanding, and same thing for caregivers or parents, is to also provide the support, explore what kind of support they have, what kind of beliefs they have, what kind of values they have, and at that point in time, what they wish for the child, and have that shared goal in a very short period of time. And that is sometimes the challenge that we face. Yeah. Pediatric palliative care is an emerging profession, I think, in the field of pediatrics. Traditionally, pediatric palliative care have been understood for and quite well accepted for cancer patients. But increasingly, we are seeing the importance of palliative care for any children with life-limiting disease or life-threatening disease. If I were to say it from the point of children with chronic disease or critical illness, I think it should be an integral part of the care delivery that we give to these children. It may not be all about death. I think it's all about support for the families and comfort for the families during the period of a very life-threatening disease. Walking the journey with the family and giving symptom relief for the child as the child goes through a chronic illness that is life-limiting. It may be prolonged, but that journey is tough. And I've seen dealing with kids with chronic disease and their families, they really go through a roller coaster ride. And I see them from the time they're in ICU to discharge to eventual demise. The journey is tough. I think the immediate part about accepting the diagnosis and what they want to do in the immediate setting, whether they want to take a child home with a debilitating illness who may need a lot of medical care at home. And preparing for that itself, I think, is a huge endeavor. Sometimes parents have to quit their job to do that. Supporting them through that process, and at the same time, making sure that the child leads a life with the best quality of life possible, and also looking after the family and the caregiver, even the siblings in the family or other family members who may be affected. I think that's important. And then guiding through them as they go through the emotions, taking care of this child, and then nearing the demise period. And also the aspect of advanced care planning for these children is often a very difficult conversation. Sometimes advanced care plans have been made, and then at the time when the child turns sick, the parents may change their mind again. And then to be able to adapt, listen, and understand their needs, that's important. I think a palliative care team that is constantly in touch with the parents, that has the rapport with the parents and have walked the entire journey with the parents, that will help the family through the process in a better manner than if they were to receive episodic care every time they come into the hospital. So to the young doctors, they are all with great potentials, be able to pace themselves well. I think there are stages in the career that they have to go through. It's a very rigorous journey, particularly for those who choose to specialize. The study never stops. The learning is continuous. So pace yourselves and remember to exhibit self-care, because don't get burnt out. If you're burnt out, then you can't deliver the care that you need to give to your patients. Take care of your family. I think particularly for a lot of young female doctors, and speaking for myself, there is always a struggle, right? When we are having our own young families, there's always a struggle on work and family. Always wanting to achieve the best in everything that we do, which is almost impossible, I think. Be able to realize that there is a time for everything. So we can see that the young female doctors often have to take a step back from, particularly those with big leadership potential, taking a step back to look after the family. I think that's perfectly fine. And then they come back when the child is older in a big way and taken on more roles. I think that is good, because they have achieved the balance that they need. So there's a time in life for everything. So don't kick yourselves if you are not perfect in everything that you do. So that's the message that I want to give to our young doctors. But just try your best and remember to care for your patients. And in order to care, there is a continuous learning journey, and do not give up. The issue of burnout, okay, I've faced it before, because there was a time when we have to do a lot of ICU shifts, and I experienced that. And when I was burnt out, I begin to be depersonalized. I find that unconsciously I begin to separate myself and build a wall between myself and the patients, and be very, very practical about things. Again, it's about science, it's about cure, and that's it. And that wall builds again. I realized that quickly, and I knew that I had to take a break, because if not, then I'm not the doctor that I want to be. So this burnout phenomenon is real. So to the young doctors, self-care is important, and always be able to reflect and be able to be cognizant of when you feel that you're very tired, that you begin to then not be able to function as you would want to as a doctor. That's a time to actually take a step back, maybe have a break, and then think through, prioritize on the things that is on hand. Some things may have to stop and have that balance. I think that's very important. And also to talk to people about it. Doctors often feel we must shoulder everything because doctors entering med school as usually la creme de la creme, but that we are not perfect and we are humans, and it is okay to talk about it. It's not about pride. It's okay to talk about your challenges to people, sometimes to your peers, sometimes to your seniors, to your mentors. There is always help to guide you along. So that's my advice.